All right, welcome to The Explainer. Today, we are getting right into the physiological changes that happen during pregnancy. Now, if you're a nursing student, this is absolutely need-to-know stuff. I'm not just talking about acing your exams, I'm talking about the core knowledge you'll use every day to keep your patients safe. So let's jump right in.
So here's how we're going to break it down. We'll start with the signs of pregnancy, then move on to confirming the due date, documenting history, a big one, the head-to-toe body changes, and finally, we'll wrap up with your role as the nurse. Think of it like we're shadowing a first prenatal visit from start to finish.
Okay, picture this. Your patient comes in, they've missed their period, and they're feeling exhausted. What's going through your head? Your first instinct might be pregnancy, but as a nurse, your real first step is to slow down and think critically. It's not about jumping to conclusions. It's about systematically categorizing what you're hearing.
All right, first up, the signs of pregnancy, and really, how we differentiate the clues. You've got to be a bit of a detective here. It is so important to understand the difference between a sign that hints at pregnancy and one that absolutely proves it. So let's talk about how we sort out the maybes from the, oh yeah, this is definitely happening.
So we break it down into three big categories: presumptive, probable, and positive. The easiest way to think about this is like a ladder of certainty. At the bottom rung, you have possibly pregnant. Then you climb up to probably pregnant, and at the very top, you hit definitely pregnant. We're moving from what the patient tells you to what you can find on an exam, all the way to undeniable proof.
Okay, starting at the bottom of that ladder, we have presumptive signs. The absolute key word here is subjective. This is all about what the client tells you they're feeling. It's their experience. And because so many other things could cause these symptoms, they're just clues, not a confirmation. They get us thinking, but they don't give us the final answer.
So what are we talking about here? Well, all the classics. Amenorrhea, a missed period. That's a big one. But hey, stress can do that too, right? Then you've got fatigue, nausea, having to pee all the time, breast tenderness, all things that could be something else. Even quickening, that first little fluttery feeling of movement, is presumptive because it's what the patient thinks they feel. Could it be gas? Maybe. That's why it's just a presumption.
Okay, let's climb up one rung on our ladder to the probable signs. Here's the big shift. We're moving from subjective to objective. This isn't what the patient feels anymore. This is what you, the examiner, can actually see or measure. These signs make you think, okay, this is very likely, but there's still just a sliver of a chance it could be something else.
Now this one might surprise you. A positive pregnancy test is only a probable sign. I know, right? But here's why. While it's a super strong indicator, some rare medical conditions or even certain medications can cause a false positive for HCG. Other probable signs are things you'd find on exam, like an enlarging belly, or these classic signs like Hegar's, Chadwick's, and Goodell's signs, which are all about softening and color changes of the cervix and uterus due to all that increased blood flow.
And here we are, at the very top of the ladder, positive signs. This is it, the real deal, the 100% ironclad, no doubt about it confirmation. These signs can't be caused by anything else. If you see one of these, you are looking at a pregnancy.
So what are these magical signs? Here's the easiest way to remember this for your NCLEX and in practice. A positive sign is anything where you directly detect the fetus. Simple as that. You either hear the fetal heart sounds with a Doppler, you see the fetus on an ultrasound, or you, the examiner, actually feel the fetus move. No guesswork, no ambiguity, just definitive proof.
Okay, so we've confirmed the pregnancy. What's the very next question everyone asks? So, when's the due date? Let's talk about how to calculate that estimated date of delivery, or EDD. This is a skill you'll use all the time.
The classic way we do this is with something called Nagel's rule. It's actually a pretty simple formula. You just take the first day of the person's last menstrual period, subtract 3 months from that date, then add 7 days. And of course, make sure you adjust the year if you cross over into a new one. Easy peasy.
But here is a huge NCLEX tip, and just a crucial piece of real-world knowledge. Nagel's rule is just an estimate. It's based on a perfect 28-day cycle, and let's be real, not everyone's body works like a textbook.
That's why the gold standard, the most accurate way to date a pregnancy, is an early ultrasound. Always trust the ultrasound over the LMP when you can.
All right, next on our list, documenting the pregnancy history. This is so important for figuring out potential risks. And to make sure we're all speaking the same language, we use a super handy shorthand system called GTPAL.
So GTPAL looks a little intimidating, but it's really just a way to pack a ton of information into a small space. G is for gravida, that's the total number of times a person has been pregnant, period. T is for term births, P is for preterm, A is for abortions, whether spontaneous or induced, and L is for the number of living children. And here's a key point to remember. If a patient had twins, that's 1 pregnancy, so the G is 1, but 2 living children, so the L would be 2. See how that works?
Now for the big one. Section 4, the head-to-toe body changes. And I mean head to toe. It is truly amazing what the body does. Pregnancy isn't just about a growing belly. It's a total physiological overhaul. Every single system adapts, and knowing what's supposed to happen is the key to knowing when something's wrong.
Let's start with the heart. The cardiovascular system basically goes into beast mode. To get enough blood to the placenta and the baby, the body's total blood volume increases by, get this, 40 to 50%. That is a massive amount of extra fluid, so naturally the heart has to pump harder and faster. Cardiac output goes way up, and the resting heart rate can jump by 15 or 20 beats per minute. It's an incredible workload.
Now, all that change leads to a really important condition you need to watch out for: supine hypotensive syndrome. Basically, when a pregnant patient lies flat on their back, especially later in pregnancy, the heavy uterus can literally squash the vena cava. That's the huge vein that brings blood back to the heart. So if you block that off, blood flow drops, and the patient suddenly feels dizzy, clammy, and just awful.
And here is your critical, must-know, save-the-day intervention. It's so simple. If your patient feels dizzy lying on her back, you immediately have them turn to their left side. That's it. That simple move physically rolls the uterus off the vena cava, blood flow is instantly restored, and everyone feels better. It protects both mom and baby.
Of course, the changes don't stop there. The growing uterus shoves the diaphragm up, making it feel harder to take a deep breath. Hormones slow everything down in the GI tract, which is why nausea, heartburn, and constipation are so common. To keep from falling over, the spine develops that classic pregnancy swayback, which we call lordosis. And on the skin, you'll see things like stretch marks and that dark line down the belly, the linea nigra. It's a total body transformation.
So, we've covered all this amazing science, but what do you do with it? This brings us to the final, and maybe most important part: your role as the nurse. This is where you translate all that textbook knowledge into real, compassionate care. A huge part of your job is being an educator. You're the one who will teach a patient why small meals can help with heartburn, or why sleeping on their left side is so important. You'll encourage them to drink more water to fend off UTIs. And just as importantly, you'll be a source of support, reassuring them that yes, the skin changes are totally normal, and listening to and validating their feelings about their body.
And underneath everything we've talked about, there is one single cardinal rule. It guides every single thing you do. And that is, you always prioritize the safety of the mother and the well-being of the fetus. That is your true north in perinatal nursing.
So, I want to leave you with this question to think about. Now that you have a solid grasp on all the normal changes, how does that prepare you to spot the abnormal? Because that's the real skill, isn't it? Mastering the baseline isn't about memorization. It's about building the foundation that will allow you to be the nurse who notices when something is off, who acts quickly, and who makes all the difference for your patient.